then I will let our colleagues here to present your own case scenario, and then we'll have the discussion in between. So the rest of the program also we have the ventilator from the ventilator. We can maybe with the. Can you hear us at the back? نقرب شوية؟ طب ما تقربوا شوية.
مش عارفة يعني.
ليه قاعدين بعيد؟ يعني لو تقربوا شوية الموضوع أسهل. So Ruben will maybe describe some of the case scenarios as a simulated case scenario with the ventilator and how we interpret with the ventilator graphs in different scenarios when we have pneumothorax or complex kind of restricted compliance or so. So is it something realistic for you to see in the ventilator?
Yes.
Okay. So we start with the case scenario and then your case scenario, and then Rob will have the ventilator after that. If we have time today, I have interactive artificial intelligence for interpretation of hemodynamics with integrated case scenario. I have integrated case scenario and how we move from the very basic assessment of the blood pressure until we have the echo done and add the echo details, and then the method spectroscopy until we get at the end a very clear impression of the underlying pathophysiologic hemodynamic mechanism and how to formulate medical recommendation based on that. So exactly what we do at the bedside as a hemodynamics consultative service. So if you have time, we do that at the end. Dr. Hisham also requested the presentation that I conducted in Dubai about nerve spectroscopy and autoregulation, how we benefit from that at the bedside, how to understand the patient autoregulation at the bedside. I'm not sure if we have time for all of that or not, but I'll do my best. And if probably, if anything missed from the day, we can maybe consider that for tomorrow workshop as well. The second case is a little bit long because it's really a challenge, and I think, yeah, it is related to ventilator support after OR. So at the end of this case scenario or presentation, you will be able to demonstrate detailed assessment of hypoxemic respiratory failure. So how we assess hypoxemia and the related physiology at the bedside. Demonstrate how to do oxygen reduction test. You know what's oxygen reduction test? Raise your hand if you know this concept. It is the opposite way of hyperoxia. When you apply increasing oxygen gradually and see the effect on circulation, it is the opposite. When you reduce the oxygen,
I usually do this.
yeah, without.
Doesn't know enough.
You practice, but it is. So we'll see that in details, and they will split along the recruitment. So we have one of our colleagues here, the RT, is applying lung recruitment on conventional, and we actually applied in a real case scenario in high frequency, but for simplification, we did it in the simulation on the conventional. So let us start. So we have a preterm 30-weeker male born with congenital phlegmatic hernia. So have you seen before preterm with congenital phlegmatic hernia? It's really quite rare. So we had this case probably 5 years ago. Remember that case? And operated at 4 weeks of age, not right after birth. So it was really a challenge to ventilate the infant before birth, and also challenge to continue because the infant developed chronic lung disease. And the infant discharged from the hospital, I think, on home oxygen for some time, but was a good outcome. I think we saw the baby at 2 years of age and was really doing very well. At 4 weeks of age, ventilated since birth on high-frequency jet ventilation. 1 week before assessment, shifted to conventional ventilation due to significant agitation. So did not really tolerate high frequency. So electively, we moved to conventional. And so and now we are at the point in this scenario, he has been on conventional for 1 week and struggling on oxygen, like requiring a very high oxygen requirement, 90% or so. So now we'll listen to the scenario with the discussion at the bedside. So yeah, I need the audio.
I'm just worried that we're missing an underlying diagnosis. I've been looking after this baby for my last few shifts, and I'm really concerned about her increased oxygen requirements and frequent desaturations. She's now been on 90 to 100% oxygen. I'm just worried that we're missing an underlying diagnosis.
Yeah, I understand your concern, and I agree we should do further investigation. I will discuss it with our attending, and will involve the hemodynamics team in order to know the mechanism of hypoxemia and pulmonary hypertension.
Okay, thank you.
He is on peak of 8, volume guarantee of 5 milliliters per kg, on FiO2 of 70 to 100% to keep oxygen saturation between 90 to 95%. Other vital signs, including heart rate, blood pressure, and perfusion index, are stable. The last blood gases results were as follows: pH of 7.39, partial pressure of oxygen of 52 millimeter mercury, carbon dioxide of 53 millimeter mercury, bicarbonate of 28, lactate of 2.1.
I've been looking after this baby.
So in
This table is showing
I've been looking after this baby from
on FiO.
So look at the monitor here. So in the monitor, the nasal spectroscopy is integrated, connected to the cardiovascular monitor. So you see this number here is the pulse oximetry. It's also not the same as Massimo. It is a Massimo technology, but connected to the big one. And it is 92, and the tissue oximetry for the brain is 90. What does that mean for you? You have the brain saturation is 90, and he's on 90% oxygen, and you have both the brain saturation and the pulse oximetry are almost similar.
No oxygen, no oxygen extraction. يعني no oxygen extraction.
Okay, so yeah, this is the point. Very good. So if you have the arterial saturation is almost similar to the brain saturation, so what is the extraction? There is no, we should expect at least 25% difference. So the brain should extract about 25%, and the venous saturation should be around 75, right? So the oxygen extraction, if we apply it as a fraction, is minimum of 15 or 0.15. That's 0.15 to 0.3 or 0.33. So what? This is what I explained yesterday. When you give too much oxygen to an infant who maybe does not require such high oxygen, the brain will vasoconstrict as autoregulation to prevent the exposure of the brain from ongoing toxic effect from the extra oxygenation. So when you give too much oxygen, that's very common to see. You will see the brain saturation is very high. It means that the brain does not extract. And that's very dangerous, very, very dangerous, because it means that the brain does not get enough oxygen, like for development or whatever. So that's why this infant was left on high oxygen for a period of time. We don't allow that at any time now. Any infant more than 50%, we have to work on to bring the FI2 down to below 50%. Yes. first, about how we know there's a pulmonary hypertension, and how we know, we need to know if the 90% is needed or not. So let us continue the scenario, and then you can ask that question.
هو 92 دي فاتحه سيماتري؟
Yes. Yeah, the Massimo is not separate. The Massimo software is connected, so we have everything in the one code. So instead of having many so monitors, so we have everything is transferred to the main monitors, including all of the numbers. We have to look at all of the numbers. The saturation have the index, heart rate, respiratory rate. Sometimes we have the M5 and CO2 monitor as well, and the brain automatic. And invasive blood pressure is very invasive blood. Here we have, we have invasive blood pressure. So 61 over 35.
Of 70 to 100% to keep oxygen saturation between 90 to 95%. Other vital signs, including heart rate, blood pressure, and perfusion index, are stable. The last blood gases results were as follows: pH of 7.39, partial pressure of oxygen of 52 millimeter mercury, carbon dioxide of 53 millimeter mercury, bicarbonate of 28, lactate of 2.1. What do you think about this chest X-ray, which was done before the intervention?
Looks like loss of lung volume.
This is the lung ultrasound, which shows on both right and left side lung atelectasis, self-pleural air bronchogram, pleural thickening, and lung ultrasound severity score of 3 out of 3 on both sides. Oxygen histograms are representing different periods, as percent in 24 hours, of the oxygen saturation, represented in different ranges. So here on the graph, y-axis is the percent of time, and x-axis is the oxygen saturation as ranges, 95 to 100%, which is representing hyperoxia, if the infant was on oxygen higher than room air. 90 to 95%, which is the target oxygen saturation, in most of the units. 85 to 90%, which is within the target, in some units. 80 to 85%, which is the range of oxygen desaturation. And at the last, less than 80% is the definition of hypoxemia. The oxygen histograms for this infant and for the last 24 hours were between 95 to 100%. The time was 57% of the day. Oxygen saturation between 90 to 95%. The time was 20%. 85 to 90%. The time was 8%. Then 80 to 85% was 5%. And the last bar, which is the important one reflecting hypoxemia, was 10%.
Okay, so you remember,
Thanks, Dr. Elsayed and Dr.
yeah, remember the 1%, how much time? If you have the day in minutes, 1% is 15 minutes. Okay? Yeah, yeah, close to 15 minutes. So when you have 5% in the hypoxemia range, below 20%, that's really significant. It means that you have more than 1 hour of hypoxemia, cumulative time.
Yes, sir. So what other information from the ventilator can you get to tell you that the baby has low volume? He show you the x-ray, he show you the lung ultrasound, he show you the histogram.
Yes.
What other very useful information can you get from the machine?
The heart rate is very high, 170. This is
Okay,
high.
but more specific than that. That tells you that the lungs now are more collapsed. Yeah, they're working, yeah, but it's subjective. What other very objective information can you get from the machine? There you are. So you haven't changed the volume. So if your PFPs were in the mid-teens, now with the lower compliance, it's going to be in the 20s. So they have been a change. So that's a very objective. What else?
Yes.
Which graph would you look at? Volume pressure. So you will see that the angle of that loop would be down. And also the opening pressure. If before the opening pressure, when you have a change of plan, was maybe a peak of 7, now it's going to be 8 or 9. because you lost volume. Okay? So those are very objective information you can get from these fancy machines. Okay?
Very good. And you will see that when we apply the language code in details. Yeah, so John Mineski is a retired cinematographer. He did a good job in this.
Film for coming. I was really concerned about this meeting. For the last week, we've been escalating our respiratory settings, and FL2 presently, this little one's on 90% oxygen, giving sats about 94, with a peak of 8 and high peak airway pressures. The NIRS is at 90, and I was wondering if you could help me to try and find a way to wean the oxygen.
Yeah.
So,
I understand your concern. We have been on very high FIO2 for almost 1 week. And when I started to monitor the body oximetry, including the brain and somatic oxygen extraction, it is very low. So I calculated the brain oxygen extraction based on the arterial oxygen saturation and the neurospectroscopy reading, and it was just 0.04. It should be between 0.15 to 0.3. So the brain is not ready, does not extract enough oxygen. And probably we can confer if the FiO2 is too much to the brain, which is affecting the brain extraction or not, by doing oxygen reduction test. So we can do it together if you don't mind.
So the oxygen reduction test that I'm going to do with you guys is I'll just reduce the FL2 by about 2% every 5 minutes.
Yeah.
And we're going to watch the saturations. And what target would you like me to keep the arterial saturation above?
We can continue weaning the oxygen as long as the oxygen saturation is above 85% and the brain oxygen saturation is above 60%. Then we should stop weaning the oxygen if the oxygen saturation dropped below 85%.
Okay. So let us watch the how to do the technique in details. Yes.
These figures are older because we used to keep the oxygen saturation from 88 to 90, but now we increase from 90 to 94.
Okay. So there are some units using 90 to 95 from the first day. We are not doing that. In preterm infants, less than 32 weeks, during the first few weeks until completed 32 weeks, we use 88 or 92, as you said. And then beyond that, because that's a ROP, expected ROP high risk period. And beyond that, there will be another period which is chronic lung disease with pulmonary hypertension period and little bit out of the ROP period, be above 32 weeks, protected age. So we move to 90 to 92 above that age. That's in most of the cases, but in some cases we apply a different ranges according to the underlying physiology. It means if you have significant lung disease with lung collapse and intrapulmonary shunt, whatever you do, you will not get more than 90%. So there is no point to put him on 100% to get the 90% saturation, and you will not, probably you will not get that. That's why we apply oxygen reduction test to understand with why applying oxygen reduction, what is the impact of that on the oxygen saturation. So you may have 90% of the oxygen, you have 90% saturation. You may have the same on 50%. So here why you get 90%. So that you will not get that until you apply the same technique that I'm going to show in the next slide. So it is generally 88 to 92 in most of the babies, less than 32 weeks until they reach 32. Over 32 will apply 90 to 95. And also in term infant with no hypertension or any term infant 90 to 95, because there is no ROB expected for that. In pulmonary hypertension 90 to 95. But in certain situations, that was my presentation yesterday, you need to apply the physiologic range. In congenital heart disease, more than 75, as long as the brain saturation is maintained. With the intrapulmonary right drift shunt, 85 to 90, as long as the brain saturation is within normal. Yeah, don't assume that the number you see in pulse oximetry is 100% correct. it is perfusion dependent, so, and assuming that we have good saturation, it is also a number range between two standard deviations. So 85 can be anything between 82 to 88, and the machine calibrated to give you the best, like the best number within this standard deviation. So it's not 100% correct. That's why when you use different technology like near microscopy, you can get a better idea about maybe lower saturation is still acceptable and still tolerated by the brain observation. Make sense?
This table is showing how to do oxygen reduction test with integrated monitoring of both arterial oxygen saturation and brain oxygen saturation. We have the time recorded in minutes, and we reduced oxygen as tolerated every 5 minutes. The oxygen reduction should be stepwise, by 2 to 5% for each step. This will give a chance for cardiovascular and respiratory systems to compensate. You need to record the oxygen saturation at each step, as well as the cerebral oxygen saturation on near-infrared spectroscopy. Then the fractional oxygen extraction should be calculated. You can continue weaning as long as the oxygen saturation is still above 85%, which is the limit of desaturation. Please note that, while weaning the oxygen, the arterial saturation decreased but still maintained above 85%. The important and interesting finding, that cerebral oxygen saturation decreased to be within the normal range, and fraction oxygen extraction also increased, signifying improved brain capacity to extract more oxygen. This is the software, which is designed for non-invasive assessment of ventilation perfusion ratio and intrapulmonary right to left shunt. First step, you need to do stepwise oxygen reduction test as described before. Then, you have to select the most matching hemoglobin level at the time of assessment. Then you have to manually enter the paired values of the fraction of inspired oxygen and the parallel arterial oxygen saturation. You need at least 3 paired values, as you can see. Then click Calculate to get the results. So, in our case scenario, the VQ mismatch was 0.1, which is very low. And as you may recall, the normal ventilation perfusion ratio is around 0.8. And the intrapulmonary right to left shunt fraction was 48%. This means that almost half of the pulmonary circulation shunted through the collapsed lung without oxygenation.
Okay.
Before considering the appropriate intervention in this case, we have to rule out pulmonary.
Okay, everybody.
So let me just pause the video. So when you apply the oxygen reduction test, you have to get a table, organize the table, and you have to record each step you do. You not just apply and keep the numbers in your mind. And the person usually doing that is John or one of his colleagues, respiratory therapist, but a physician anyone can do it. And you need to record, if you don't have near field spectroscopy, then record it as a pulse oximetry number and then oxygen saturation at the same time. And you need to wait some time, you have to be patient, because if you do it very quick, you don't give enough a chance for the cardiorespiratory autorespiratory mechanisms to compensate for the changes. And also there is a time lag. The pulse oximetry does not record immediately. There is a time lag in seconds between the actual saturation and the number that you read in the monitor. And the monitors are different according to how much time actual compared to the time that you see the actual saturation on the monitor itself. And then the software is available online. It is based on a lot of studies done to assess the ventilation perfusion mismatch non-invasively. You know, the invasive way to assess the ventilation perfusion mismatch, you need isotone scanning for the lung. And that's really, like, we have done it just very few times in many years. But this is very applicable way to let you know the magnitude of parenchymal lung disease in this infant before the intervention. So we'll do the intervention and we compare after the intervention how much ventilation perfusion matching improved, and also how much reduced right-left shunt. Now we have almost 50%, almost 50% of the lung not working, just shunted blood without getting any oxygenation. So let us continue the scenario, and we'll see how we can fix this challenge.
Okay, everybody, we start the PEEP study. Are you ready?
I think we missed the step.
This
So now John is applying the deep study. Now we understand. Yes, yeah, I think there's a part which is missing. Yes. Okay.
This table dynamically significant PDA by echo. At the same time, we have to assess the filling volume of the heart before the next attempt to increase the distending pressure of the lung.
Hi everyone, thank you for asking me to do the target metal echo exam as part of the hemodynamics assessment for the mechanism of hypoxemia. So I will start with the apical for chamber view. So we put the probe with the index mark to the left side of the baby and probe over the apex, and then we give the apical for chamber view. So here I can see the four chambers of the heart, the left atrium, left ventricle, right atrium, right ventricle, and from the first plot, the right side is smaller compared to the left side, which is against the diagnosis of pulmonary hypertension. And then if we add clamp to this view, you can see the filling of the left side of the heart is good. So you have the blood flow from the left atrium to the left ventricle, so the blood flow, and the left ventricle is contracting well, as well as the right side of the heart. That's a photograph of the mitral inflow, which looks normal. That's a tissue Doppler of the septum and the full body of the left ventricle. That's mainly for research purposes. And then I just move the probe slightly anterior to bring into the view the left ventricle and flow tract. So you can now see the blue flow of the left ventricle outflow, which is aortic outflow tract. And then by applying the pulsar Doppler to the left outflow tract, we can get the envelope which is reflecting the blood flow in the left ventricle. From this envelope, the blood envelope, I can measure and decrease the blood flow and measure the cardiac output, which we can do that later, calculate that later. So I'm just tracing the blood volume, the Doppler of the left ventricle outflow tract. So I have the number here, and then I need the diameter of the left ventricle outflow, and the heart rate to calculate the cardiac output. So we can do that later. Now I will move the probe to the parasternal long axis view. So the index mark here towards the right shoulder of the baby. So now I can see the most anterior part of the heart is the right ventricle, and then the septum, the left ventricle, cavity, mitral valve, left atrium, aortic valve. And from this view, I can assess by any mode the left atrial aortic pressure. And that's more important marker to assess if there is a patent left spondylosis. Because in PDA, we expect the left atrium to be dilated compared to the aorta as an index to the left atrium. So the ratio, in case if you have pulmonary hypertension, the right ventricle should be more dilated, which is not in this case. And then if you have even more severe pulmonary hypertension, then the right ventricle will be more dilated, pushing the septum more and more, and the septum will be paradoxic and pushing the left ventricle, and the left ventricle in this case will be like a crescent, always more thick. So thick not contracting well, or there's RV dysfunction, and that's very common also in pulmonary hypertension. So that's very important to evaluate, because in this case, if there's pulmonary hypertension with RV dysfunction, we may consult to use merlinone to improve the right ventricle performance. Now you have the black area here under the right ventricle wall, the cavity of the right ventricle, and then you have the septum again, and the septum is also wavy. So you have the thicker in systole, thinner in diastole, and the black area under the septum is the left ventricle cavity, which is dilated in diastole and less dilated in systole. It means that you have difference between systole and diastole, so the blood is injected well during systole. And then you have the posterior wall of the left ventricle, which is also way thicker in systole and thinner in diastole. So the inward is reassuring that the right ventricle is contracting well. The right ventricle is smaller compared to the cavity of the left ventricle, which is against the diagnosis of the pulmonary hypertension. And then we have now the short axis view of the pulmonary outflow tract, and looks normal. And then with the Doppler, we can also, the same as we did with the left ventricle outflow tract, we can measure and trace the blood volume to calculate the cardiac output for the right ventricle, which should be the same, equal normally to the output from the left ventricle. If they are different, means that there is something wrong going on. It could be PDA or it could be pulmonary hypertension, because in pulmonary hypertension we have the left ventricle is better and higher than the right ventricle outflow. In this case, we measure the crease from the pulmonary outflow tract. So just a place around the organ. To get the volume calculated, and we get the volume calculated here as VTI, volume time integral, and I will show you later how to calculate the cardiac output from that. And then the last view here, I have the arch of aorta, and there is no electric flow, and probably we can move the probe under the left clavicle to show the ductal cuff. And in the ductal cut, you can see side by side the descending aorta and the pulmonary with the extension of the pulmonary branch. If there is a PDA, it should be a red color between the blue flow of the descending aorta and the blue flow of the pulmonary artery, because the ductus will be moving the blood against the flow of the pulmonary artery. And the against the flow means a different color, so the color will be red. So you have the like side by side, the descending aorta and pulmonary like banana side by side, like banana. So we have the descending aorta and pulmonary, and the PDA should be in between there. So we are done with the echocardiography. So we would have a pulmonary hypertension at the same time the close.
So, Yasser, what's the mechanism of hypoxemia that's happening in this?
Yeah, that's a very good question. So we already ruled out pulmonary hypertension and fetal ductus arteriosus. The mechanism which makes sense also with the oxygen reduction test that we did before, lung atelectasis was under inflation of the lung and also significant intrapulmonary shunt. Because when you have significant lung collapse, lung is under recruited, then the blood could be shunted from the right side to the left side through the lung without getting enough oxygenation. So whatever you increase the FiO2 even to 100%, or we need to 60 or 70, you will not get significant change in the cardiovascular situation, which already happened when we did the oxygen reduction test.
So, Dr. Bellin, what I think we can do, we have no pulmonary hypertension, and we have all the monitors, we have SATs, we have blood pressure. So I'll recommend that we could do a best PEEP study. What we'll do is I'll turn the PEEP up by 1, and leave it there for about 10 minutes, and then see if the FiO2 stays the same or goes down, or maybe we can do it. And then I'll keep doing that to, let's say, a maximum peak of around, how much would you feel comfortable with me going on the test?
So how much are we targeting?
Well, I'll target stats again, at least 88%, 88 to 94, at that lowest FiO2. Make sure your blood pressure doesn't change and the heart rate stays the same. Okay, and then those are the ideas, but I can go higher. And we just say if we're at 8 now, 15, 8 high. And then, of course, watching ventilator parameters to make sure nothing is out of sorts.
Yeah, I think that's a very good plan. So we can keep going higher until we reach that level, and at the same time we have to watch the vital signs. Because with the hyperinflation and the heart getting compressed by the hyperinflation, you should see that on the monitor. So the heart rate and the blood pressure should be affected. And you may see also narrowing of the pulse pressure when you get less carbon output from the hyperinflation. So you can watch that on the monitor at the same time while John is doing the PEEP study.
Okay, so the next is still how to do the PEEP study. So let John do that in front of you. And then probably after that, Ruben maybe show on the ventilator here how to do while everyone is around, like the same idea, and maybe with more discussion about the graphs. Okay?
Okay, everybody, we'll start the PEEP study. Are you ready? So what I'm going to be doing is adjusting the PEEP by 1, and then every 10 minutes I will be taking vital signs to make sure that we don't overdo it. To start, I've checked the compliance, and it's quite low. It's only at 0.2. So by no means is it good. Very good.
Yeah, before I carry on, so the compliance is available on the machine. Are you looking at the compliance on a regular basis when you apply changes? The compliance. Yeah, do you have an idea the normal compliance for infants as a number? Yeah. What's the equation of the compliance first? Yeah, this is like it, yeah.
She's a respirator.
Okay, very good. But yeah, we need to hear you. Yeah. Okay, so it is a change in volume as per it's a change in pressure. So we need to see the relationship between both. How much volume created and how much pressure needed to make that volume. So the relationship between both. It is usually 1 to 2 millimeter mercury per centimeter water.
Units for infants with 0.9, right?
Sorry?
The units and the normal components, 1 to 2 with every kg.
Yes, it is very effective. We are using
For
the kg.
infants,
Yeah.
for infants with 0.9. 0.9.
0.9.
Yeah?
Yeah. So we are usually more familiar with the units we are using the kg, but yeah, you're correct. In infants we are using units, but very good. Yeah, well done. Thank you. So let us see that with Prof, and also we'll get more hands-on with Ruben and our fancy Draeger machine. And we have the Draeger team at the back ready to help.
What we're going to be watching from a respiratory point of view, because we're using volume cardiac ventilation, is if we increase the peak and we open the lungs, we should be able to deliver the volume at the same pressure or maybe even lower. So this is why we're not too overly concerned as we're going up on the peak, as long as we're watching all the parameters at the same time. Okay, so presently we're on 70% with a peak of 8, and everything's okay. Sats are 88.
Yeah.
Okay, and you got your blood pressure and everything like
Yeah.
that.
So John, while you're doing the PEEP study, I'll just make sure to really be monitoring her heart rate, her oxygen saturation, her blood pressure, as well as the tissue oxygenation. And as you mentioned, I'll record that every 10 minutes.
Yes.
So if you just let me know what your PEEP and FiO2 is, I'll record that as well.
Perfect, thank you very much. Okay, so we got our baselines, we have all your numbers,
Yeah.
70%. Okay, so I'm gonna up the peak from 8 to 9. Okay. And we're gonna watch and see if that's making any difference in occupations. And we should expect, within a minute or two for us, if we're going to see pressure changes for them to be reflected. And we're hoping that the pressure is not going up, they're staying the same or going down, and our variables are staying the
They're
same.
stable, yeah.
And we're going to see if the saturations are going to be going up with this one. Yeah, and we are, as you see, right off the bat, without changing the FL2, the saturations have gone up. So, everybody, Dr. Bellin, we finished the peak test. We've gotten to a peak of 15, and this is where I feel a little bit uncomfortable. But we have a sat now 93. We have an FL2 of 30%. Our peak air pressures are roughly the same, not higher. And the compliance does look a lot better over here. And I believe all the vital signs as you checked.
Yeah, the vital signs have improved. The heart rate's come down to 154 from 170, so that's great. And as John mentioned, our stats are up to 93 now and much lower oxygen. Our blood pressure has improved as well, and our tissue oxygenation has stayed the same. I'll just do a quick listen to hear for air entry. It sounds much better, especially to the bases.
I think then we should do the
Absolutely.
Okay, sounds good.
Thank you.
This is the table that our neonatal management team is using during the lung recruitment by stepwise increase in PEEP. The baseline PEEP was 8 and was gradually increased up to 15 centimeter water. At the same time, the team recorded all of the parameters in the table. Compliance from the machine, which was 0.8 before lung recruitment, then improved to 1.2 at the end of lung recruitment. The required PIP to deliver the preset volume was 32 centimeter water at the beginning, then decreased to 28, which reflects improved compliance. Baseline oxygen requirement was 70%, then improved to 35%. Oxygen saturation was maintained within our target saturation, between 86% to 94%. Cerebral oxygen saturation did not change, although the fraction oxygen extraction improved. Pulse pressure, which is a reliable marker of compromised cardiovascular dynamics in case of overinflation of the lung, was maintained within the normal range. This is the chest X-ray after the lung recruitment, and you can recognize the improvement in lung inflation and volumes after the intervention. This is the oxygen histogram for 6 hours after lung recruitment. For the oxygen saturation range between 95 to 100%, the time was 7% of the day. Oxygen saturation between 90 to 95%, the time was 60%, then 85 to 90%, the time was 31%, then 80 to 85% was 1%, and the last bar, which is the important one reflecting hypoxemia, was 0%. Now, let us summarize the lessons from this case scenario. This slide is reminding you about the common pathophysiologic mechanisms of both hypoxemia and hypoxia. Regarding hypoxemia, which is prolonged oxygen saturation less than 80%, it can be due to limited diffusion, which is common in bronchopulmonary dysplasia, pulmonary edema, and RDS. Right to left shunt, it is common with severe lung collapse, as intrapulmonary shunt, or it can be intracardiac shunt. Hypoventilation can be due to low tidal volume or low respiratory rate. Lung congestion is common in left to right shunt. Pulmonary hypertension can be due to either increase in pulmonary vascular resistance or pulmonary overcirculation. Then the most important mechanism is VQ mismatch, which is the common mechanism in most of the parenchymal lung diseases or lung congestion. Steps of lung recruitment in infant with hypoxemic respiratory failure. First step is the baseline clinical assessment, which includes 1. Detailed history of any potential predisposing factor and related diseases that could lead to a specific pathophysiologic mechanism. 2. Proper assessment of oxygenation including oxygen indices, histograms, blood gases, and software for non-invasive assessment of VQ mismatch. 3. Pre-intervention chest X-ray or lung ultrasound. 4. Pre-intervention oxygen reduction test, and we have explained how to do the test at the bedside. Performing echocardiography by a trained neonatologist is an important step in assessment to rule out pulmonary hypertension and hemodynamically significant PDA. And you need to assess all of these parameters in this slide. Then applying the appropriate intervention as follows. In limited diffusion, consider to treat the underlying cause, for example, RDS, BPD, or pulmonary edema. For hypoventilation, you need to adjust parameters of ventilation, which are tidal volume and respiratory rate. Then, you should consider appropriate lung recruitment strategies if there is ventilation perfusion mismatch with intrapulmonary right to left shunt, which was the main pathophysiologic mechanism in our case. Pulmonary hypertension with high pulmonary vascular resistance should be treated with pulmonary vasodilator after appropriate lung recruitment. The most important lesson from this case is that we should not accept higher oxygen requirement without detailed assessment of the mechanism of hypoxemia and apply the physiologic specific medical recommendation. Post-intervention assessment should include the followings. 1. Proper assessment of oxygenation, including oxygen indices, histograms, blood gases, and we have explained how to use the software for non-invasive assessment of VQ mismatch. 2. Post-intervention chest X-ray or lung ultrasound. 3. Post-intervention oxygen reduction test. 4. Consider weaning after a period of stabilization, which is usually 48 to 72 hours in chronic cases. 4. Continue assessment of the above oxygen parameters during the process of gradual weaning. At the end, I would like to thank all of the staff participated in this scenario, and thank you all for attention.
هو السيناريو ممتاز يعني، بس اكثر حاجه ملفتة للنظر ان لما جينا نعمل ريكروتمنت للرن وصلنا لبيك 15. ودي انا اعتقد ان لازم سينيور ستاف يبقى هو متاكد انه واقف كده ان العيان ممكن يعني ينشر.
So what's your worry about 30? Maybe a leak?
Yes.
Yeah. So in this case,
يعني ما اعتقدش يعني احنا ساعات فعلا بنرفع بيك، بس ممكن في الهايبر بس في الكونفشنال فنتريشن يوصل 8 9 حتى ساعات sometimes واحنا واقفين for 10 minutes then decrease the gauge.
So let me answer the concern that maybe Robin would like to answer as well. So in a real scenario, when you recruit with such high peak, usually we do the high frequency. In this case, the issue is not really ventilation. You know that the value of high frequency jet over the convention is mainly for ventilation. For oxygenation, we need to recruit a lot. That you can do on convention, up to whatever number of P. Now with the new machines that we have for non-invasive ventilation, we can use even 20, up to 20 non-invasive. So you're worried about the air leak syndrome. So let me clarify that. During the postnatal transition early period, usually we don't exceed 8 on either invasive or non-invasive because of risk of pneumothorax. In such case, this infant had operated and now is almost corrected age of 36 weeks, is really old, was chronic lung disease. The pleura is really very thick and fibrosed. The chance of development of pneumothorax is almost close to zero in this case. When you have postnatal transition, I really worry about pneumothorax.
Even we said this case, and a lot of audience recognize that we could be 10, 11, and 13.
No, like that.
Yes,
see how many persons
situation on not a very tiny RDS.
No, RDS is different. Like more than like 7 or 8 is not accepted. 8 is a maximum during transition because pneumothorax is really expected, and we have to consider surfactant even more than 1 dose. But this infant with chronic lung disease, the pneumothorax is unlikely, and we see how many persons are around, and everyone knows exactly what he is doing. The bedside nurse, she's keep watching the blood pressure, all of the vital signs. If there is any hyperinflation, our worry in this case not in the results will be really hyperinflation. In hyperinflation, you should see the impact of that. Reduced venous return, you will see the pulse pressure affected. And if we are really concerned about hyperinflation, we need more sensitive test, echocardiogram, you will see the heart compressed. Or even you can see that in the X-ray as well. So that's our main worry when we have hyperinflation, like reduced venous return or the impact of cardiac output. You will see that in vital signs for sure, and you confirm that by echocardiogram. But that's very good point to consider. Not everyone can do that. We need as a trained, the most senior person. So how many persons? That's the most senior RT. The nurses, the nurse educators. She's a CRN. She's educating the other nurses, and she's taking care of the most sick baby, which is, makes sense in this situation. And also we have the in-house staff, and everyone knows exactly what's going on, and the person, which is expert in hemodynamics, is controlling the scene, controlling everything. So everything is still under control. If you have the least senior person or team, which they are not really understanding what's going on, that might be at risk. I agree with you. That should be under control. So any other question before maybe give a chance for Ruben?
I just want to make a comment that even if you don't have all the expertise, like you don't have Yasser, you don't have the nurse educator, you don't have a senior team, you shouldn't accept a baby to be on 90% oxygen with low volume. Okay? You may not be able to do the whole recruitment maneuver, but you should be able to adjust your P up until at least. So you may not go up to 15 because you may not be able to assess the heart, but you should be able to start increasing the P by 1 slowly and see what type of changes you get from the machine.
Exactly. And that's the part that we are going to maybe apply the game on the machine now, and probably we have the team. Can we use artificial language?
الدنيا برد قوي قوي قوي. ممكن اروح. هل هم نفس الشيء؟ بيلعبوا في التكييف. احنا عايزين التسجيلات دي ما تنزلش كده على الفيسبوك بسهوله. كات كات
دكتورة مايا. يا خليفة. قدامك كتير؟